Okay, and welcome to the Davies Use Case webinar being presented by Rush University on inpatient substance use screening initiative. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievements of organizations from around the world who've utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable and improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar, Kristen Hill from Rush University. Kristen, I will turn the presentation over to you, and you can begin when you're ready. And thank you for joining us today.
Hello, my name is Kristen Hill. I am a practice administrator in the Department of Psychiatry for the Section of Population Behavioral Health at Rush University Medical Center. I am here to present our substance use intervention team, which we affectionately call the SUIT team here at Rush. We are an interdisciplinary team that work on an inpatient substance use screening initiative as well as an outpatient clinic. Our motto is Suit Up, as we are raising awareness for better care. And this, at the bottom, you'll see a clause that says these services are supported in part by a contract to Rush University Medical Center from the Illinois Department of Human Services, Division of Substance Use Prevention and Recovery, as part of the Illinois Opioid State Targeted Response Grant from the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration. And so that is there because we received a SAMHSA grant through the state to launch this program. So a little background on opioids. The opioid epidemic has been around for a couple years now. So everyone has been made aware of the rising deaths that are recorded each year across cities and states in the U.S. and worldwide due to overdose deaths of opioids and other drugs. So this map is from the CDC, and it displays rising, both the trend line for male and female, and the total number of deaths that have occurred from 2002 to 2015. So you can see a huge jump from 2014 to 2015. That's kind of when a lot of the rhetoric was going around about the opioid epidemic. And opiates are a class of painkillers or drugs that includes naturally derived drugs from opium, such as morphine and heroin. So over the last 15 years, there has been significant increase nationally in the rate of drug overdose deaths, including opioids. And there's been a lot of recent mandates for clinicians to decrease their opioid prescribing. Unfortunately, the death tolls has not drastically decreased. And so we've actually seen an increase over the last 3 years and continue to see that now that we're moving into 2019, the numbers have been growing still. So this is to zoom in to Chicago. This is a map of the Chicagoland area and all of its counties or neighborhoods. And what you can see is the opioid epidemic and the heroin epidemic. You see similar dark areas where the epidemic is especially hitting hard. And the yellow star represents Rush University Medical Center, where our hospital of these communities, and you can see it gets very dark right to the west of us. Um, and number 23 is Austin, and then you have East and West Garfield Park right there, and North Lawndale. So in these areas, what we're trying to show you is that the total number of overdose deaths for involving opioids in 2015 was 647. In Chicago, we see that the rate is 50% higher than that of the national rate of 10.4 overdose deaths per 100,000 people. And so we really have a mandate to follow and a cause to impact with our program. And so we see that also 81% of the deaths from opioids specifically involved heroin, and the majority were accidental. And so this is what kind of fueled our initiative. So Rush then made a commitment to the crisis. And in response to the opioid crisis, we developed a comprehensive program to provide opioid screening and treatment for patients identified as opioid users on our medical and surgical inpatient units. So our goal had several aspects, and this is kind of what went into the grant that we applied for. And so the first of which was screening our inpatient admissions for substance use disorder using the SBIRT methodology, which as you can see on the bottom of the screen, SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. We also had another leg of our intervention around launching the inpatient consult service, which would be the actual people who would respond to a risk stratified response to the screening that was administered inpatient. We wanted to also launch an outpatient clinic that could land these patients for those who are started on a medication for addiction treatment inpatient. They can then be seen outpatient to continue their treatment or move them to other levels of care. We also wanted to launch an ACGME accredited addiction medicine fellowship program, which launched October of 2018, in which we have our first fellow now with our team doing outpatient and also in the community. And in the grant, we wrote that we wanted to provide treatment services for 1,200 patients in that grant year. So the SUITS inpatient program workflow. So this is a diagram that shows all of the components of our program. Our program launch date was October 23rd of 2017. So we are just over a full year in. So we started working with our IS, our information services, electronic medical record analyst. So we worked with them. We had an inpatient analyst, Mark Moon, and an outpatient analyst, Mandisa Upton, and they were able to build all of the flow sheets and templates and workflows and all of the components within the electronic medical record that we needed in order for our program to flow. We also have the 2 patient question screening, which starts with our nurses. That's the orange bubble. Then we have an aspect of our intervention that goes to the social work on the floors, and that is the SBIRT, or Screening, Brief Intervention, and Referral to Treatment, and the motivational interviewing intervention. And then we have in the purple the substance use intervention team. That is the consult team that includes an attending physician who is an emergency medicine medical toxicologist. We have an advanced practice nurse practitioner who is a psychiatric nurse practitioner. We have a social worker, and we have a pharmacist. They are all involved in the inpatient intervention. And then there is the substance use intervention team clinic, the outpatient clinic that is here on campus, in which all of the players, inpatient, also participate outpatient. And then we have another full-time licensed clinical social worker doing therapy there, and a medical assistant rooming patients for our providers. So why universal screening? We wanted to create an intervention that could reach the largest amount of people that we were already seeing, and we knew that within the group of people we were already seeing within that population, there were people in need. And so we decided that we would input questions into the admissions navigator that will allow everyone to be asked. And so, in decreasing bias and decreasing stigma, we wanted everybody to be included. We didn't want people who, quote unquote, looked like they had drug issues or people who were presenting specifically with diagnoses for substance abuse. We wanted everyone to be screened because we know that the opioid epidemic and the substance use epidemic touches everybody. There's no race or socioeconomic status that singles people out or excludes people from being at risk. And so, in decreasing bias and stigma, we wanted to have these conversations with everyone about substance use, about prescription drug use, and have these questions be as easily asked and easily answered as questions about blood pressure or age or eating habits or anything else or any other social determinant of health that may come up. So from there, we have how Rush program addresses the barriers to treatment. And so there are always, as you know, barriers to treatment within all aspects of healthcare. And so we wanted to do our best to open up access to care, open up affordability, and to educate patients and staff. So in access to care, the universal screener used the existing electronic medical record. Here we use Epic. In the admissions process, there's already a host of questions that the nurses must go through, and so we just wanted to insert our questions right into their workflow that they were already using. Also, our clinic has two Suboxone providers, so we really wanted to have a landing place and give patients access to Suboxone providers who may not already be in their current networks or close to our location, so that everybody can have access to a Suboxone provider should they need one. In efforts of increasing affordability, our consult team and outpatient clinic are staffed by emergency medicine trained medical toxicologists. And this was an intentional decision made on the part of our leadership because a lot of the insurance companies that our institution works with or that patients have often have a carve out for mental or behavioral health, which means that patients may be able to come here for emergency medicine care. They may be able to be admitted into our hospital, but they may not be able to be seen by a psychologist or a psychiatrist. And that is one of the unfortunate realities of our healthcare system. And so to try to navigate through some of that, we were able to use emergency medicine toxicologists who had the training in addiction to see these patients without having to go through their carve outs. And then education, there is education provided to patients on the bedside, giving them their options for medication for addiction treatment, whether they want Suboxone or methadone or Vivitrol. All of these options are presented to them and the side effects so that they can make an educated decision on what type of care they want moving forward. We also do naloxone training, and give out Narcan to people, so that is an effort against overdose. So for patients or their family members, for them to have that, so that if their loved one or themselves are ever in a situation of overdose, they have the tools to kind of navigate through that and at least get to care at an emergency room. So our selection process for the IT. We chose the EMR for the reasons listed. Ease of documentation, that's what our providers are already using. We wanted to encourage continuity of care so that um, different, whether the patient is inpatient or outpatient, all of those records can be seen and reviewed by providers. We wanted to encourage multidisciplinary communication so that nurses can speak to social workers and social workers can speak to providers and physicians can speak to each other. So we really wanted everyone to have access to everyone and communicate with each other through the mechanism of the medical record. And then we wanted to increase the universal screening methods, right? We wanted everyone to be screened equally with the same questions at the same point in the process. And we wanted to decrease bias by having these conversations, as well as we wanted the flexibility of being able to implement this screener or change these questions or make any kind of changes to what was going on that we needed to make due to the feedback of our team. This is quite a busy slide, but it lays out the process and the different aspects that we had to prepare in order to roll out this intervention, right? So we have to engage IT so they can build into our medical record all of the components of our workflow. We have to engage nursing and social work as they are the soldiers on the ground. They are the ones who are going to be asking these questions. So we had to engage their leadership. We also had to provide educational materials for them so that they knew what questions to ask, when to ask, and what resources they had when asking these questions to patients. And also inform them on the opioid epidemic, on what Suboxone is, on what kind of barriers to care some of these patients may have. We also had an education task force where we were able to provide cards that slipped into the pockets of white coats that had the audit and the DAS, which is the questionnaires that the social workers use to assess the level of treatment that a patient may need. We were able to create a website that explained our initiative, as well as had some educational materials for our providers on the website. We put up flyers and table tents around the university and the medical center so that everyone can know about our intervention. And so we had to kind of prime the ground. And then, of course, we had a clinical addiction medicine task force that did some of the preliminary work of saying, hey, we really need to do something to address this epidemic. They changed the protocols for withdrawal from both alcohol and opiates in the EHR. And of course, we had to obtain the grant and create mechanisms in which we knew what tools we wanted to use at different aspects of the intervention. And we continue to hold monthly meetings with this task force to really monitor our intervention. So that's kind of the full layout of all of the players that had to come together in order to make this intervention a reality. So what are our outcomes? Well, for our SUIT team, we have 4 outcomes listed here. We wanted to improve on early intervention to provide the best medical care. We wanted to identify a population of patients in need of treatment for substance misuse, and we wanted to provide comprehensive treatment for those patients that we were able to identify that needed a need, and ultimately to reduce the length of stay and readmission to our medical center for this population. And so we really wanted to impact the entire continuum of care and really help our patients from the moment and give them the best medical care from the moment they show up at our doors to when they leave, and follow them well. So here is the intervention. Redoing the slide. Okay, so here is a full picture of the inpatient intervention. And so kind of referencing a previous slide in which we had the components listed out in kind of a hierarchical structure, this kind of details what happens at each of those stages. So The inpatient nurses, they give a 2-question screener. The questions are listed here. How many times in the past year have you had 4 or 5 drinks in a day? And then how many times in the past year have you used a recreational drug or used a prescription medication for a non-medical reason? They can either answer none or one or more. From there, if one or more is selected for either or both questions, inpatient social work is then notified and alerted to come into the room and complete an audit or a DAS screening based on the question. So if they say one or more to alcohol, they complete the audit. If they say one or more to the drug or both, they'll do the DAS, which is the drug questionnaire. And so once that is complete, that further risk stratifies them into the type of treatment they will receive. So some patients will only need a bedside psychoeducation, maybe a little bit of motivational interviewing from the social worker. And they have a flow sheet and epic in which they can complete to designate that they've completed their intervention or a higher level of care was necessary. And in their flow sheet, they can recommend that the suit team be involved. And the suit team is when our multidisciplinary team will show up at the bedside of the patient. They round every morning on all the patients who get added to their consult list, and they're able to see the patient and say, okay, they can assess what type of treatment the patient would like, what they're ready for, what they can medically handle. And then the social worker can go in and orchestrate an appointment to our clinic or connect them to services outside of our institution that may be more appropriate than our clinic. Should a patient be fit for our clinic, we can see them. Our clinic is connected to the inpatient hospital or right across the street, depending on how you want to get there. And in that clinic, we do medication for addiction treatment. There is psychotherapy available, and there's case management available. So from the moment they get here until after they are discharged, there is a level of care available to patients. And this is what we mean by comprehensive care. Moving deeper into the inpatient intervention, here is another very busy slide of our intervention. And so on the right side of the screen, we have how the 2-question nurse screener appears in the medical record and how they can select a response. There's also a deferred needs follow-up if a patient is unable to answer, and that alerts our team to go back in at a later date or a later time in the day. And then this is kind of a snapshot of what the DAS, the drug abuse screen test, or the audit and the intervention look like in the medical record, and that's what our clinicians and providers are using. And you can see kind of it's time stamped for a time and a date so that we know when these screenings happen. And on the other side, you can kind of just see how people trickle through the intervention. And so there's a 2-question screen. The audit and the DAS are both 10 questions. And then there's an intervention. We were able to receive feedback from our social workers and update our intervention team, our intervention portion of the workflow and the flow sheets in Epic. And so we went live with this new type of intervention flow sheet in August of 2018. We can see we broke out what the floor social work is responsible for and what the suit team was responsible for. And this just kind of demonstrates the fluidity of using our electronic medical record, that we can make these changes and implement them and keep things flowing evenly and still access data and kind of overlay data. And the fields that we use are clear and concise, clickable, discrete fields that are easily reported on the back end. And so we were just able to capitalize on our relationship with IT and their readiness to help us and to serve us and see the real time of implementation, intervention, feedback, and change all at once. This is another component of the electronic medical record that we were able to use. So there are patient lists that each inpatient unit has. And in the patient list, we were able to create a column that is entitled substance use. And each of these icons represents a different stage of the intervention that a patient can be at, and alerts the next team on what they should do. And so if patients haven't been screened, you'll see the first icon, and that alerts nursing and social work that they should go in and screen the patient. They haven't received those first two questions. And the flow sheets and the navigators that the nurses use and the social workers use are connected in that either one of them can answer those questions and both of them can see the answers to those questions. And so they can rely on each other to really be as efficient as possible in completing the intervention. The black dot means that none was answered as for both questions, and so the intervention for that patient is complete and no further action is needed by any of the teams. A positive screen means that one or more was selected for one or both questions, and it resembles a stop sign with an exclamation mark, which lets our inpatient social work know that they need to go see that patient and do a further screening, motivational interviewing, or an intervention with the patient. The green check mark means that social work came in, did their intervention, and no further action is needed. If the blue line or the red circle with the two exclamation points signifies that social work went in, they did their intervention, and they recommend that this patient be seen by the consult service. And so our consult team then gets a work queue report of all who has been recommended to us, and the primary teams can put in a formal consult, and they see these exclamation points, and they know I should go see this patient today. And then there's a yellow dot if screening is deferred for any reason. If a patient is recovering from surgery, intubated, having heavy withdrawal, unable to communicate, then we know as soon as that patient is able to communicate, we can go back and start the intervention all over again. So tangible outcomes. So we have an intervention, we're ready to implement, then what? So our tangible outcomes, we wanted to collect data from the inpatient screening and interventions. We wanted data, and we have collected data from our addiction medicine clinic. How many appointments, how many patients, who's being seen, what are our retention rates. We have data about the length of stay for patients with a secondary diagnosis for substance use who received a suit consult and their readmission rates. And we wanted to, of course, collect all of the data that would be necessary for our reporting back to the state of Illinois so that we can continue to receive our grant. And this is our data. So what we were able to do, from November 2017 to October 2018, there were almost 35,000 patients admitted to rush to the medical and surgical units in which we were screening. So we were screening in about 20 of our units in the hospital. Of those almost 35,000 patients, 31,274 patients received our initial two-question screen, asking them if they had misused alcohol or drugs or prescription drugs in the past year. So that gave us an 89% screening rate, of which we were immensely proud. And moving through, right, so of the 89 people screened, 5%, or 1,400, just over 1,400, of them received a second level of intervention from our social workers. And our social workers, that means that our social workers went into the room, denoted and dashed with them, recorded those scores, decided that they may need motivational interviewing or a little bit of psychoeducation, and completed that intervention with them. And the brief intervention was completed by 97% of that 1,400, right? So 1,390 received an intervention from our social workers. 53% of those people, so 740, received a suit consult. That means that the primary team put in a consult in the medical record that told our team that they should come by and start some type of medication-assisted treatment or link to care. And then 99 patients in 1 year time were started on buprenorphine during their inpatient stay. And so that means that we were able to get them all the way through the intervention, start them on a medication while they were inpatient, and connect them to continue that medication once they were discharged. So this is the book. This is our data. This is the proof that's in the pudding. This is what we're very proud of, and the work we hope to continue. One thing we really want to highlight in our intervention is the identification of a new and unique population. And so early on, it was speculated that perhaps we would just take patients away from psychiatry and really impact their consult orders and just deal with people who were already suspected to have had issues with substance misuse. And what we found was that was not true. And this consult to addiction medicine was really aimed and targeted and succeeded at giving the right screening to the right patients to get the right treatment at the right time. And so we see pre-suit, before we were in existence, psychiatry had 752 consults. Once we were in existence, right, in the year from November 2017 to October 2018, psychiatry's consult orders did not statistically change. And what we were able to do was find a whole population of people, 841 people, who needed a suit consult and who received one and were able to get care that was appropriate for their presenting conditions and their diagnoses. And what we also found was that while it takes an average time of 4 days for psychiatry to be consulted, it only takes about a day and a half for the teams to consult us on average, which means some people are consulted sooner, some people are consulted later. And of course, there are other medical conditions impact these numbers, but what we found is people, when it is identified, because we're asking this in the admissions navigator, because this is one of the first, because we engage discussions about substance use as soon as we engage the patient, we're able to impact care a lot earlier. And you'll see that it also helps us to decrease length of stay. And I'll talk a little bit more about that in just a second. And we wanted to further highlight this with a quote. So I guess a term of speech would say the word on the street is that if you go to Rush, they will help you. And patients are coming here, receiving help, and going back out into their communities and letting those around them know that I went to Rush and I was able to get help with my substance use in a comprehensive way, in a non-judgmental way, and that if you want help, they will help you. And so we see that Patients are ready and willing when they get here to receive help, and we are ready and willing to give them help. And so, again, this is something else we're very proud of and really want to highlight in identifying this population and being a force on the West Side where the epidemic is strong as a place of refuge for patients and people in the community. This slide shows our length of stay and the length of stay data. So you can see this is specifically for patients with a secondary diagnosis for substance use. Um, Substance misuse is only a secondary diagnosis here. It can't be a primary. And so we were able to look at that specific population, and of those who received a suit consult and those who did not, how and observe their length of stay, right? And what we found is for patients who did receive a consult, their length of stay was about a day shorter than those who did not receive a suit consult. And their mean length of stay was 1.02 days shorter. Um, and while this is a trend that we see and are proud of, and it turns out that decreasing length of stay by a day um, corresponds to lots of money being saved by our institution. And so some have estimated that this could be like $1 million saved in a fiscal year. Some can estimate that it is more. And so this is money that did not have to be invested into the upkeep of the rooms, the staff, everything that goes into an inpatient stay. We also looked at 30-day readmissions and saw a positive trend in decreasing the 30-day readmissions among patients who received a suit consult compared to patients that did not receive. So we are continuing to track this data to see if we can get a real statistical difference between these two numbers. And while they are different, we need more data to really be able to stand firm on these findings. But we do see a positive trend in decreasing the length of stay. So for the outpatient data, so far I've really talked about our inpatient data, and that was the heart of our intervention. But on the outpatient side, we see steady growth in our clinic. And so from January through October, when our clinic was fully staffed and ready to go, we had about 12 patients over 33 appointments, and now we see 66 patients over 140 to 150 appointments in a month. And just to kind of give you a little bit of background, when a patient comes to our clinic, they're usually receiving several appointments. So they can receive an appointment for case management if they need connections to other types of care. They can receive therapy from our social worker, and they can receive a medication management appointment from one of our physicians. We try to consolidate all in the same day so that they come and they can see the social worker and receive medication assisted treatment all in one day. Sometimes we stagger it, especially patients that we want to touch multiple times a week, or make sure that we touch them every week to help them navigate through their treatment and have ongoing support. But that's why you can see it's almost always like a 3-to-1 ratio of appointments to patients, because most of our patients are seeing multiple providers in our clinic for those wraparound services and support that we want to provide our patients with as they are journeying through their treatment for substance use. A little bit more about the nuances of our use of the electronic medical record. So on the ambulatory side, we wanted to be able to collect the same data that we collect on our inpatient side. Some of our patients don't come from inpatient when they come to our outpatient clinic. Some transfer over from another dual diagnosis clinic that we have on campus once they are psychiatrically stable. We've also been opening up our social work and therapy services to other types of patients. And so we wanted to make sure that we had some parity in the data that we were collecting. And so we were able to work with our IT associates and create flow sheets that can be used on the outpatient side that mirror the same data we were collecting on the inpatient side. And of course, this encourages continuity of care and improves our communication so that if a patient is inpatient and they go into outpatient, we can see that data. If one of our outpatient ends up going inpatient, that data is also available for our inpatient staff. We were also able to provide note templates for our social worker and our physician providers so that they can easily document their visits as well as pull in the audit or the DAST or any other assessment or the intervention workflow or anything right into their note from that has already been captured in our medical record that allows for comprehensive charting and ease of charting. And so we're very proud to have that type of ease and those mechanisms from our medical record. And we were also able to use the discrete fields and the flow sheets in our medical record to pull data that is easily reportable to our funder or the state of Illinois. And so the state of Illinois, you'll see on the right side of the screen, sent us things that they wanted us to keep track of every month. So they want to know how many patients receive each part of our intervention and who gets connected where and how many consults are we doing. And so this allows us to easily pull that data from the flow sheet and aggregate that and report that to the state every month. And so this is another luxury we have in using the electronic medical record and allows us to easily manipulate data on the back end so that we can have accurate reports sent to the state every month. And so just to wrap things up, this again is a busy slide, but we wanted to show you again our intended outcomes next to what we were actually able to complete. And so we were able to implement this universal screening for substance misuse, both alcohol and drugs, across 20 units in the medical center, as well as the emergency room department. We were able to identify a unique population in need of substance use and establish ourselves as an anchor for addiction treatment on the west side of Chicago. We were able to leverage our electronic medical record to implement the screening and brief intervention and referral to treatment methodology and workflow to work to engage patients in the inpatient world and then follow them through treatment. We were able to collect compelling data from our electronic medical record to support our grant reporting and also support our program. We were able to establish an outpatient clinic to provide medication for addiction treatment, psychotherapy, psychoeducation, and case management to patients. And we were able to decrease the length of stay for patients with a secondary diagnosis for substance use who received acute consults, and also are seeing a decrease in readmissions for these same patients. And so this is our intervention in a nutshell. This is what we desired to do, and this is what we were able to do. We were also able to launch our fellowship program and have trainees come and learn more about how to treat patients and expand our capacity to see and treat patients as well with their presence on our clinical team. And this is the suit intervention at Rush University Medical Center. Thank you.
Okay, and we would like to thank our speaker from Rush University for joining us today and sharing their Davies story. This information, this story can be found along with other important Davies use cases, recording, and information on how to apply for Davies. All of that can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Again, thank you for joining us today, and have a good day.